from an adult patient. You all know that hemodialysis in adults started in 1942. This is the first trial of hemodialysis in adults. 7 years later, a trial of hemodialysis in children has been done in Boston. So it's only 7 years difference between the start of hemodialysis in children than in adults. But the difference is more than that. We have a lot of differences between hemodialysis in children than in adult, and this is a talk of, or this is the main theme of our today presentation. Before I start, do any one of you have any experience with hemodialysis in children? No. So all of you are an adult. You don't have any chance to, so I can say anything. Okay, you have. And you? Only two cases. And you?
Excuse me.
Few experience.
Excuse me, Professor Ashraf. What is the cut-off point of the definition of children in your country?
Age of consent.
And what is the age of consent? 21?
No, 16 years.
16 years. So you can deal with children up to, or more than 16 years, you are
More than
eligible.
16 years, they are.
Okay.
No, in my country it's
40.
40. But it's not age of consent. It's
Yeah.
just more of logistic problem.
But you sterilize the children and adult in the same year. Is it true?
Yes.
In the same year. Okay. So we are going to stress on when should dialysis start, the hemodialysis facilities, the vascular access, the hemodialysis equipment, the prescription, and the frequency, duration, and finally we will have, some points or some few minutes about the dialysis adequacy in children. When should dialysis start? We all know this graph, and this is the Kidoki guidelines for staging, or the Kidoki definitions of stages of chronic kidney disease, and we have, as you all know, from stage 1 up to stage 5, and usually dialysis start in adult patient above or in stage 5 of kidney disease. The situation is the same in the children. We should dialyze the patient if they reach the stage 5 of a chronic kidney disease. But we have some situations in which we can, or we should start dialysis before this figure, before this number. These situations are, number 1, the poor growth, the poor development, the worsening of the school performance, or the deterioration of the nutrition. So we don't always stick to number. We have some situations that we can, or we should start dialysis earlier than we reach the figure of 15 ml per square surface area of GFR. But we have some doubt about dialysis in certain situations, especially those who have severe peripheral arterial disease, the hypertensive heart failure, the patient with severe mental illness, and the patients who have a malignant disease. In this situation, the decision is more and more than a medical. But if we not allowed to do dialysis in this patient, at least we should give him a trial of dialysis for 1-2 months, and then we can manage them as indicated. This is how we can estimate the GFR. We all of you, the calculated GFR is with stress on the Schwartz formula, as you all know. Let's move to the second point. What are the hemodialysis facilities? The dialysis unit and the water management unit. The hemodialysis should be, and this is very important message, hemodialysis in children should be delivered in a pediatric dialysis center, away from an adult. The kidneys of the children are not young adults, and this is very important message. We are not dealing with a young adult. The children are completely different from adults. And the dialysis unit in children should include a dietitian. Beside the nurse and the doctor, we should have an dietitian. We have social workers. We should have a teacher, because these children spend most of their time in this unit. So these are the new family of these children. So the dialysis unit should be done in an isolated unit away from the adult, and the dialysis unit should include all of these personnel. The nurse staffing here also is different. We should have one-on-one. If we are going to dialyze a child below 5 years of age, we should have one-on-one. A nurse for every child who, if he's below 5 years, and if he is above 5 years, we need one nurse for 2 patients. It is also recommended that the maximum distance between the dialysis unit and the home of these children should not exceed 25 miles. 25 miles or 30 minutes walk or 30 minutes drive or time between the dialysis unit and the home of these children. Okay. The required number of hemodialysis stations should be based on using each station for 2 patients per day, 3 times per week, and I think this is the same for adults also. And the home hemodialysis till now is generally not recommended for children. A transfer process is a very difficult decision for both for the doctor and also for the children to be transferred from a pediatric unit to an adult unit. It's a very difficult situation, a very difficult decision, and usually are faced by many problems from the patient themselves to move from the unit that they have been transplanted for dialysis for a long time to an adult unit. The water quality in a hemodialysis unit in children is similar to the adult, about the frequency of assessing the chemical composition or the bacterial toxin. These are the same recommendations as if we are in an adult unit. What about the vascular access? For the temporary access, the preferred mode is the double lumen central venous cath. And we prefer to insert this unit in the internal jugular, not on the same side as planned for maturing upper lip fistula. And the subclavian should be avoided as much as we can because of them that may be occur in the fistula at that time. The native arteriovenous fistula is the preferred permanent vascular access, and the fistula should be created 6 to 12 months before hemodialysis is expected to start, and we should wait at least 4 weeks before creation of dialysis through this system. The figures are not fixed, but we should depend on our clinical assessment of the fistula. What about the machine and the composition of the dialysate? You all know that we have a hemodialysis and a hemofiltration, a hemodifiltration. The hemodialysis is the diffusion is the method of the solid transport, while the convention is that in the hemofiltration and the hemodifiltration, both of 2 processes are present. And you all know this figure by heart. For all the patient or all the physician who are dealing with dialysis know this figure about the difference between diffusion and the convention in the removal of the different toxins in patient with end-stage renal disease. Online hemodifiltration is now recognized as the most advanced hemodialysis treatment modality in children. It's first introduced in 1974 in children and adults, and in children they started hemodifiltration from 1982. And this is a paper was published several years ago about the efficacy of the online hemodifiltration, and they stated that the children, parents, and the team care discovered a new way of life with motivated children showing natural compliance, no diet restriction, no or few foods, and most of the children developing with catch-up growth. So the hemodifiltration is an ideal method for the dialysis in children. But you know that the expenses and the precautions of the water management system. But it is preferred for those who are going to a long-term chronic hemodialysis in children. Of course, the machine should be replaced even for the conventional one after 7 years service, or about 25 to 40,000 hours of use for dialysis. For the composition of dialysate, it is similar in children as in adults, but bicarb hemodialysis is a must children. Bicarb is the must, and we go to from 300 to 800 ml per minute for the dialysate flow rate in our patients. How we can prescribe a dialysis session for this? The first point, as you all know, is how to estimate or to measure the dry body weight. And you all know what's meant by dry body weight. It is the weight at the termination of a regular dialysis session below which the patient will become symptomatically hypotensive. It is very difficult in children. Why? Because the hypotensive tendency during dialysis session is a multifactorial one. Also, the body mass is variable with age, especially during infancy and the puberty. So we need a regular assessment. Don't stick to a fixed dry body weight. We should assess the body weight several times by trial and error to reach the optimum dry body weight. Also, there is no unique optimum method for estimation of the dry body weight in children. We all know this table about the different methods used for assessing the dry body weight, from the serum ATR tetrapeptide, the venous cable diameter, the viral venous, the BDM. All of them, as I told you, they don't have an fixed or not any one of these is superior to the other. Each one has advantage and disadvantage, and there is no unique method for assessment of the dry body weight in children. What about the dialyzer? We all know that we have different classification for dialysis. For the dialyzer, for the configuration, the material, the permeability, and the biocompatibility, and in the bio, and for in children, the synthetic and modified cellulose, low flux membrane can be used, and the evidence here is 2C. So we can use a synthetic modified cellulose low flux. And this paper, which has been published many years ago, they try to compare between the cellulose, modified cellulose, and synthetic membrane in the hemodialysis patient with end-stage renal disease. And the researcher here concludes that there is no evidence of benefit when synthetic membrane were compared with cellulose, modified cellulose membrane in form of reduced mortality, reduction in the dialysis-related adverse symptom, despite the relatively large number of randomized control studies undertaken in this area, none of these studies include a measurement of the quality of life. So it seems that both are equal. But if we are going to a chronic hemodialysis in children, the use of more biocompatible dialyzer instead of unmodified cellulose seems justifiable on the basis of evidence of biological benefits and equivalent. So we can use both, but if we are going to long term, the best is to go to the more biocompatible dialyzers. The high flux membrane should be considered, especially in chronic long term, as I told you, because now hemodiafiltration is a preferable mode of dialysis in children, so we could go to the high flux membrane, which may, because it has many advantages, remove urea and other urine toxins, reduction of urine amyloidosis, maintenance of residual renal function, and reduction of inflammatory processes, malnutrition, anemia, and dyslipidemia. The use of dialyzers sterilized with ethylene oxide should be avoided, and the level of evidence here is 1C. ACE inhibitor drugs should not be prescribed in patients who are receiving hemodialysis with synthetic membrane, which are capable of generating bradykinin, and the evidence here is 1. What about the size?